Okay, hi everyone. Good morning, good afternoon, and good evening to everyone joining us from different parts of the world. Welcome to our webinar on cross-border travel in the COVID-19 era. Today's agenda is as follows. We'll have a short overview of the webinar by the chair, followed by very quick presentation from cross-border studies. And then we'll hear from our international stakeholders, followed by a discussion. And the chair will summarize key points and end the webinar for today. So let me introduce the chair for the session very quickly. Associate Professor Hwee from the Swee Hock School of Public Health from National University of Singapore. She's been part of and leading several components of the studies that we'll be presenting today. So without further ado, over to you, Hwee, to start the webinar for us.
Thank you very much, Sarin, for the kind introduction, and welcome to all our attendees today. Thank you so much for joining us, and a big thank you to all the participants, the speakers, the presenters. Yeah, so to begin, I think this webinar comes at a time which is probably more appropriate than we would have expected. So initially we thought that our work is going to end here with Delta variant having been a predominant variant around the world, but now with Omicron on the horizon, and it got us thinking again, when is this going to end? What's the best way to react to new variants, etc. So I do hope that you will find this webinar useful as you ponder how to manage the latest situation with regards to COVID. So for today, we have got two speakers followed by a panel. And essentially what we aim to do today is to present evidence on the economic and public health impact of alternative testing and quarantine policies for reopening countries. We hope that the information will be useful, and we will also be presenting data on perception and use of vaccination certificates in Asia. And the panelists are invited to give their quick reactions to the presentations and share their organization's perspective on the work that has been conducted. Yeah, so that will be for today, and we look forward to your active participation as our audience to put in your questions in the chat. And for colleagues from Thailand, I believe that you would be able to select the interpretation button to listen to the session in Thai. Yeah, so back over to you, Sarin.
Thank you, Hwee. So today I'll be presenting on behalf of my team our findings from a regional study on vaccination certificates, which has come from this initiative called COVID-19 Research, and this is a support initiative, or CORSIA for short. CORSIA leverages research expertise and partnership from 10 different countries in Asia, and also utilizes expertise from multidisciplinary, from ranging from health to other sectors. And our objective is to support COVID-19 related policies, and in particular, provide guidance to policymakers in Asia on the use of vaccination certificates. So as you can see on the left-hand side, we have created a website. Hope you can check it out. It's called vaccert.info. There are some cool features and also helpful resources. So what did we do through CORSIA? So we did 2 online surveys in the 9 member countries in CORSIA. The first one is among the public, general public, and the second one is targeted at national stakeholders from organizations from public, private, health, and non-health sectors. So from the public survey respondents, majority of were female. Most of them were between the ages of 25 to 40, fully vaccinated, and with AstraZeneca as their main vaccine of choice. So what did we find? We found that majority of people do want vaccination certificates, and primarily for international travel and less for resuming in-person employment. But those who do want vaccination certificates, they do have certain conditions. Public health safety remains a major concern for both public and stakeholders. among our respondents, and therefore they want to see all the NPIs, existing NPIs, testing, quarantine, and others to continue as they are. They also want national vaccination coverage to be 60% or higher. In terms of cross-border policies, people and stakeholders both prefer more testing and less quarantine. I think we can all relate to that choice. And when we ask stakeholders, they want this testing and quarantine policies to be risk-based, depending on the traveler's country of departure. And I think both this need for continuing testing and continuing NPIs, vaccination coverage, and risk-based policy speaks even more and is more relevant in light of this new variant that our chair highlighted earlier. We also find that there are certain groups who are opposed to the idea of vaccination certificates or vaccination passports. So we tried to run regression analysis, logistical regression analysis to find who they are. We created 3 models. We tried to group countries who have less than 1,000 response, more than 1,000 response, and also pooled all the responses together. And we find the results are pretty consistent. So the 2 key groups that we find who oppose the idea of vaccination passports are those who are unvaccinated, and they are 5.5 times more likely to oppose vaccination certificates as compared to those who are fully vaccinated. And also those who have no travel plans in 2021 and 22, and they are 1.5 times more likely to oppose vaccination certificates compared to those who have travel plans. So when we try to dig deeper into the reasons why people were not getting vaccinated and try to see whether they accept or reject the idea of vaccination certificates, we find that people with no intention of getting vaccinated are 47 times more likely to oppose the vaccination certificates as compared to those who are already vaccinated. We recognize this number is quite large, and it may be driven by a low sample size, as majority of the people in our sample respondents are already vaccinated. Although we ran this analysis at individual country level, we find the results are consistent, although the size and the magnitude of this odds ratio tend to vary, but the direction remains the same. We also find other reasons, for example, still considering getting vaccinated, want a different vaccine, not in priority group, awaiting their first dose, vaccine not available in their country, still remains significant, and help predict who are these groups that still oppose the idea of vaccination certificates in the country. The other interesting findings from our study is that there is lack of consensus in the region, but also globally, regarding the type and format of certificates to be used in the country. So when we say type, we mean vaccination-based or immunity-based, and also the format, either it be electronic or paper-based. So this finding has led us to think that adopting both types and formats are necessary for all the countries and the region as a whole to ensure that adoption is accessible and also equitable to all groups. While this is good, we also highlight that there are challenges that lie in adopting both types and formats. If you look at vaccination-based, there is still lack of consensus on which vaccine is recognized globally or at the regional level. In terms of immunity-based, do we consider antibody tests or proof of prior infection? What about the validity of these proofs? So these are still uncertain areas that we need to find a common ground on as a region. There are also challenges regarding the format. For example, interoperability, data privacy, and data infrastructure for the electronic, and for the paper-based forgery, authentication, and also updating new information. So we also asked how much do they trust the public in their government and also the private sector, as highlighted in blue and orange. And we try to see if this is influenced by their government's performance during COVID-19, proxied by vaccination coverage, but also COVID-19 deaths and COVID-19 cases. And we find that for vaccination coverage that is close to 20 or higher, people tend to trust their government more than the private sector. As you can see, 20% or higher, India, Laos, Singapore, Malaysia, South Korea, and also Japan tend to have trust in their government more than in the private sector, and also vice versa is true. Bear in mind that these figures are taken during the survey period, so it may not reflect now, but it certainly reflects at the time the survey was being conducted. Another interesting finding from our survey is that the financial loss, as shown by this green, the red area, is far greater than the perceived financial gains from vaccination certificates, as shown by this blue area. So as you go away from this spider web, the magnitude of loss or the gains tend to increase. So if you look at India, the financial loss caused by COVID-19 is around 80%, but the anticipated financial benefits is only at 40%. And the results are consistent across countries, but the magnitude vary, and that may be driven by several factors. Majority one being their dependency on tourism and service sector. So 3 key takeaways from our findings. People want vaccination certificates, but NPIs must continue. Vaccination remains key to accepting vaccination certificates. And we hope that policymakers can use this information to incentivize people in the future and tackle vaccine hesitancy in their own countries. Second, there are ways to make vaccination certificates an equitable policy and more accessible, but there are challenges across all these methods, and policymakers could think about these issues and try to address them as soon as possible. And one of the key thing that comes from our result is that public trust could prove very important, and this is linked to their own performance during COVID-19. Finally, vaccination certificates may not be the magic bullet, and it may not help recover financially to our pre-pandemic levels, but they can certainly help. And by talking and sharing these results, we hope that policymakers can utilize and make the most out of these results. So over to you, Hwee. I end my presentation here.
Thank you very much, Sarin. This is very comprehensive in a very short amount of time. I would say that your last statement in particular, vaccination certificates may not be the magic bullets, will be one big discussion point that we can have with the panelists later on. We know there are many limitations, many concerns over the use of vaccine certificates, and it will be a great thing if we can discuss with the panelists later. So we'll move on to the other 2 presentations, and we'll do the panelist discussion at the end of all 3. So coming up next, we have Dr. Borame Dickens from Hock School of Public Health. Essentially, the question that we have asked her to consider is, how can we reopen safely during the COVID pandemic? So we look forward to hear from you, Bo.
Hi there. Good afternoon. So originally, we were tasked this project quite early on, seeing that we had an issue of what to do with our borders on the advent of a new pandemic. So when COVID-19 was first being reported up in Asia, we immediately started this task force to try and examine what to do. So essentially, sorry, next slide. The problem statement was that we wanted to reduce and somewhat manage the risk of COVID-19 importation. Now, this was particularly challenging at the time, as we weren't sure completely about the parameters of COVID, but we understood that we just couldn't have free flow at the borders, because we could essentially end up with a lot of cases appearing within the community. And at that time, our community was largely susceptible, and therefore we tried to manage this risk. So these models were essentially tasked to quantify the risk of the number of missing infections and the onward transmissions from these missed infections by using such interventions at the time which were available, including pre-departure testing using a PCR antigen test, a rapid antigen test, on-arrival testing using different quarantine lengths of time that went up to 21 days, of which we observed in Hong Kong was being the sort of maxima, and with quarantine testing. So that's testing during quarantine as well as exit testing, and that would be testing upon the exiting of quarantine. So the reason we looked at these two tests was primarily at the time that we understood that there was a bargaining between both. PCR is more accurate and sensitive. However, it does take a longer time, up to 2 days or 3 days, depending. And I think early in the epidemic, even longer to process to get the results to turn around. And then we have rapid antigen testing where the results are incredibly fast, 20 minutes, but we understood that there was this payment in terms of sensitivity loss. So by using both, could we actually find an ideal set of scenarios of what we could do at our borders to try and manage this risk? So the overall aim was therefore to see whether we could reduce this quarantine time or perhaps manage this quarantine time by using more testing events, as we understand that quarantine time is particularly unfavorable for travelers and the economics alike. So these models that we created have been presented to many stakeholders, including those of the Singapore government, Australia, Japan, New Zealand, Sub-Saharan Africa, Thailand. So, and it continues to be developed now, especially with the advent of Omicron, which we are now nervously waiting to see what will happen next. Next slide, see. Thank you. So essentially the model in its structure is essentially a group of people who have been affected up to 2 weeks pre-departure. So uniformly across, and we assume that this is a body of people that are going to be traveling. We didn't go beyond 2 weeks simply because I think mostly by that point they've cleared the infection. So upon arrival, they can be tested either with PCR rapid antigen testing, depending on the strategy, subsequently more and more and more. Once we positively identify them, we remove them from the model. So they've been safely quarantined and therefore then isolated after they've been identified. And essentially after this point, those who remain unidentified are the ones that we are most concerned about that we're trying to model. So if you imagine that a group of travelers arrive, they get potentially pre-tested with their results. If they're obviously tested positive before they arrive, then they're not allowed to travel. Upon arrival, they get tested, potentially removed, and they get potentially sent into quarantine, and then they get tested however many times we decide. And then upon the release of quarantine, we calculate the proportion of that population, which are still either in the incubation period or in the infectious period or somewhere past the infectious period. And then we examine what that looks like in terms of, okay, this proportion of people will still be infected and or infectious, depending if they're released from quarantine or just simply upon arrival. So these were the kind of questions we were looking at how to model. Sorry, next slide. So we modeled 400 plus scenarios, and this actually went up into the thousands. We looked at different prevalences of different sort of couplings, I could say. So one country being the origin, one country being the destination. We had many such combinations, and we were trying to examine how to manage the risk. So when we say, okay, 14 days quarantine to a stakeholder, and they say that's too long. Okay, so then let's say 7 days, that means you have to have 3 more tests, for example. These are the kind of questions we were dynamically looking at for a long period of time. Sorry, next slide. So one such example we were looking at earlier on was this suite. We did these often in suites, building up more and more interventions to see, okay, what was the ideal point. So for strategy 1, we assumed a pre-test for PCR with a 2-day delay. So that meant that an individual was probably going to get their PCR test 2 days before they travel. And if they're identified, they're removed. So that was our first strategy, the bare basic. Then we added on a PCR pre-test for 2 days and then a rapid antigen test on arrival. And then no quarantine. We just removed those who are potentially infected. And then the third strategy, we had a PCR pre-test, antigen test on arrival, and then we had 2 days of quarantine, which the PCR test was done the day before with an expected turnaround of 24 hours, aka 1 day. And then for the fourth, we had the delayed PCR test towards the end because the quarantine was longer. We had it at 4 days and we had the PCR test on day 3. And the final strategy we looked at was having 2 PCR tests during quarantine on day 3 and day 5, with quarantine lasting up to 6 days long. So if you look on the second part of the figure, you can see strategy 1, 2, 3, 4, 5, which I've just explained. This is looking at the percentage of people who essentially are still infectious or infected upon the end of the strategy. So for example, with just a pretest, you're looking at 31% of individuals being still infected and infectious upon arrival. So therefore, looking through, you can see that if we have an assumed prevalence of 2.5%, that is 250 travelers out of the 10,000 potential travelers are infected, then it goes down from 250 to 78. And then each subsequent intervention we add on, that number gets substantially reduced. So of course, with things like vaccination and other such strategies being taken in such origin countries, that prevalence can go rapidly much less. So we're looking at perhaps potentially in this day and age for some countries a prevalence of 0.15%. Therefore, what we're looking at is potentially at the end of the 5th intervention, 1 or less travelers being potentially infectious upon the intervention completion upon release of quarantine. So essentially it's a balancing act. So the final slide, please. So what we were looking at was a potential balancing act. So this model framework was trying to apply its findings to all border situations with different prevalences and very complex situations regarding the percentage of people who are vaccinated, non-vaccinated, because we understand in some situations, being vaccinated is not so simple. There's vaccine supply issues, there's testing supply issues. So we have to be very flexible. Therefore, this was supposed to be sort of a very dynamic framework in that essence, not just applied to Singapore where tests are relatively easy to obtain and vaccination is also relatively easy to do. So we were looking at the risk profiles and tolerances of different combinations. Some countries may just not accept any cases whatsoever. We look at our neighbors such as China that are just simply trying to really go for this zero COVID case approach. We have to think of strategies which would work with them also. But ultimately what we're looking at is a very short quarantine time for everyone being the most optimal solution, because it allows travel and palatability, and the willingness to travel therefore increases because of that. So economic cost as well is something which one of my colleagues will also elaborate on much greater detail. That's something that we have to also consider in some of these strategies that we were looking at. Now, this is a especially important point with the advent of Omicron. We were looking at this model with the idea that widespread community transmission had not occurred yet. Therefore, this model is trying to protect the community essentially from the importation of these cases, which can spur on to all these outbreaks within the community. That might no longer be the case with vaccination being so high, although that is hotly contested and still remains so. But should we have new strains where perhaps it is more naive presence in the population, then perhaps then we have to reconsider these border strategies once again, or even adapt these strategies that we already have now in the model now to account for this idea of more like management at borders, to understand how many cases we're getting in rather than let's try and prevent the number of cases that are coming in. So that was essentially the modeling approach that we continue to do today. So looking forward to any questions anyone might have later. Thank you very much.
Thank you, Bo. I'm sure there'll be many questions related to that. So as you have mentioned, we'll also be looking at the economic cost of various testing and quarantine policies. And next up, we have Dr. Jing, also from the Swee Hock School of Public Health, to share with us the economic analysis of border control policies using Thailand and Singapore as an example.
Thank you, Hwee. Hello, everyone. Based on the transmission model, we further did an economic analysis of border control policies between Thailand and Singapore. So the objective of this study is to optimize COVID-19 testing and the quarantine policies between Thailand and Singapore for economic recovery. In this study, we assume only vaccinated people are allowed to travel because it is likely the case in the near future. For quarantine length, we allow it to vary from 0 day to 14 days. And for testing strategies, they differ in whether we have test or no test at all. What is the type of test for pre-departure test upon arrival, and test at the end of quarantine? So this could be either ART or PCR. And for quarantine test, we assume we always use ART test, but they may differ in the testing frequency during quarantine. One thing to note is that the turnaround time of PCR is assumed to be 1 day, so that as long as PCR is used as the entry test upon arrival, then the quarantine length is at least 1 day to wait for the result to come out. So in order to find economically optimal policy, we incorporate a group of factors. The first one is willingness to travel, reduced by length of quarantine. When quarantine length gets longer and longer, it does provide better protection to the country. However, long quarantine will discourage people from travel. So according to the observational data, we found 1 more day of quarantine reduces number of tourists by about 20%. This will reduce the economic gain in tourism sector. So the second factor we consider is the receipts in tourism sector. When there are more inbound travelers, there is more tourism receipts from them. Besides inbound travelers, we also have outbound travelers. They contribute to the tourism receipts by paying for air tickets. However, for the outbound travelers, when they stay in the other country, there is some opportunity cost. That is, the local expenditure will be reduced. The implementation of testing and quarantine policies also incur cost and profit. The cost of testing and quarantine on outbound travelers throughout their trip will be counted on the home country's head, but the expenditure by inbound travelers on testing and quarantine within the destination country will give the country profit, as the price is usually higher than cost. Because international travel may cause more transmission, so we also consider treatment cost on COVID cases. This includes outbound travelers, secondary cases resulting from inbound travelers and returning outbound travelers, and cases from local transmission. The treatment costs on the inbound travelers are not counted here from the destination country's perspective, because inbound travelers themselves will pay for the medical costs. And at last, we quantified the health and productivity loss due to isolation and COVID morbidity and mortality, and they are translated into monetary terms to quantify economic impact. After we quantifying the net economic gain of all the policy combinations, we find 3 Pareto optimal policies based on economic gains. As we could see, if we just consider economic gain alone, then no quarantine at both sides is for sure the best. This is mainly because quarantine will reduce people's willingness to travel. But for the testing options, the optimal testing choice is between no testing or having ART pre-departure and upon arrival. So PCR does not stand out here, possibly because of high testing cost per se, and its limited ability to reduce secondary cases, and more importantly, because having PCR entry test requires at least a 1-day quarantine, which will reduce people's willingness to travel. Oh, sorry. Then after we disentangle the cost and the benefit components, we further find that bigger economic impact comes from the receipts in the tourism sector and the cost and the profit of implementing quarantine and testing. Compared to that, cost and health loss associated with COVID transmission have relatively smaller economic impact. This is because transmission only happened to less than 1% of travelers, because the prevalence in both countries are lower than 1%, while the other compositions will happen to every traveler. Indeed, they will have bigger economic impact. So those are what we found from the economic analysis. However, those Pareto optimal policies may only be feasible if they do not challenge the country's COVID risk and COVID risk tolerance and testing capacity. So the final decision should be based on the economic result, transmission result, and other feasibility checks. So that's it for the economic analysis. Thank you.
Thank you very much, Lo Jing. So we kind of like had a whirlwind tour of 3 very important studies that we couldn't cover in detail, but our esteemed panelists, they have already taken a look at the slides before this and spent some thoughts, and here I'll be hearing from them, their reactions. So first up, we have Professor Kang, Gagangdeep Kang, from full professor at the Christian Medical College, Vellore, India. And next up, we would have, I'll just introduce all the panelists first. Next up, we would have Dr. Ninglan Wang and also Ms. Natschja Ratanaprayul from World Health Organization. And then we have Mr. Vinoop Goel from International Air Transport Association, or more commonly, we refer to them as IATA. And last but not least, we have Datuk Prof. Awang Mahmud from Secretary General of Academy of Sciences, Malaysia. So we will have 5 minutes for each of our panelists, and then we will have open discussion after the panelists have spoken. So thank you very much. Over to you, Professor Kang.
Thank you very much. So I'd like to make 3 key points, and to all of the presenters, thank you very much for the presentations and for sharing the slides beforehand. It was really useful to go through them and to hear from you about the approaches that have been taken to begin to look at what vaccine passports can mean for countries in the region. So one of the things that Omicron has brought up is the fact that there is a huge amount of variability in how countries have decided to handle the incoming variant. From complete shutdowns to selection of countries to thinking about, what kinds of testing needs to be done on different kinds of incoming passengers. And one of the approaches to consider is how we get alignment across countries and regions so that we have a uniform policy and not a knee-jerk approach that is developed for every new pathogen that comes through. And in order to do that, it would be very useful to hear from all of you and the work that you have done about considerations around rapid antigen tests versus RT-PCR. RT-PCR, you said, has additional cost of a one-day quarantine being required. And possibly we could think about rapid antigen tests on 2 days being a way of leaving people more functional while still taking the bulk of individuals out of circulation based on an on-arrival rapid antigen test. The other thing that I wanted to discuss was this is for cross-country border migration, and yet we have in the region very large countries that have provinces or states that make different recommendations for travel, that have different policies for incoming travelers. And this impacts populations. For low-income countries, it's important to understand that only a segment and a small segment of the population is going to be traveling internationally. But a lot of economic activities depends on domestic travel, and thinking about what vaccination passports and testing strategies can mean for in-country travel, I think is also going to be very important for helping policymakers to develop strategies for what needs to be done with vaccination passports. As we saw from Sarin's presentation, in general, people who want to travel are more likely to comply with requirements that are placed on them than people who are not intending to travel. And if we look at Southeast Asia and at public expectations, I think in our countries, the expectation of compliance, if a policy is put in place and you want to do something, is much higher than in many other parts of the world. So if a policy were to be made that vaccination passports were required or an infection history passport were required, people who were intending to travel would comply with that. I understand the compliance cost, the reluctance to travel internationally, but I'll come back again to domestic travel and its importance and the likelihood that our populations would be more likely to be compliant with documentation requirements than other parts of the world. Of course, flip side of that is that there's also a robust business in fraud, in making sure that documents, especially paper documents, that certify vaccination are already a big business in many countries in the region. So I will stop there and come back in the next cycle. Thank you for having me, and again, congratulations to all the researchers and speakers.
Thank you very much, Professor Kang. Those are very insightful comments. We will come back to them for the speakers to respond later. Next up, we will hear from the World Health Organization. So I understand that there is a general reluctance to mandate vaccine certificates. Can we hear from World Health Organization your perspective on this and also on the other two presentations? May I know if Ninglan is speaking first?
Yes, I can start, and then I pass the floor to my colleague, Nat. So thank you very much. Just wanted to add my congratulations and to this very informative session, and also the speakers to present all this presentation. I think there's a very useful findings, because at this moment we're really, the entire world has being caught off guard by this Omicron. So I think that's really the right moment that we discuss all these issues. So just wanted to share with you, because before I start with my comments, and I think it's good to also share the travel advice that we just issued on November 30th, so just a few days ago. As you can imagine, that we have been working really hard for starting from last week and during the weekends, and just wanted to make sure that we have some policy also advice and for the countries, and during this moment that we still have many unknowns about this Omicron. So knowing that the Omicron has a multiple mutation which enhance their capacity of transmissibility, and also unknowns about the severity of the disease, and also this potential impact on the immunity escape or reinfection. So we just wanted to countries still remain vigilant and wrap up their response and surveillance and sequencing capacities. And for travel, we continue to apply that to the evidence-informed and risk-based approach, because understanding, again, each country has your unique context, right? The health servants and the health service capacities and your epidemiological situations, and also the countries pairing with you for the international traffic. So all these context-based factors need to be factored into your assessment. So again, we continue to recommend this approach, and of course then implementing all the possible travel-related risk reduction measures, testing, quarantine, knowing there are risk residual anyway, because no matter what type of test and what type of testing regime prior to travel, during, upon arrival, and the quarantine, we always have risk residuals. That's why I think the risk tolerance, as one of the speakers presented in the presentation, I think is very important to know. And because that's basically give you the threshold, what type of measures you wanted to inform. So in this travel advice, we continue to recommend the national authorities to looking at the entire travel continuum, what are the measures could be put in place for departure, transit, and arrival countries, and to reduce as much as possible the travel-related risks. However, we understand the quarantine is always factors that somehow disruptive to international travelers' willingness, and also their the country's capacity of doing that, because that bears the financial cost. Whether this should be the countries and the travelers, this has been a hot topic. Although under the IHR, we know that all these travel health related measures should be borne by the country level. So this is continues to be a very debatable issue. And I think that we recognize that. So however, we still recommend, because the IHR, the countries signed up for IHR, so the compliance with the IHR is still very important to bear in mind. And then the other thing is the blanket travel ban. We know that will not stop or prevent the international spread. Although we know we have the modeling studies and observational studies saying at the very beginning of the pandemic, and if you apply that at very early stage, it can buy you a few days or 1 or 2 months, and based on the context, but we know eventually it will not prevent the international spread. And I think this Omicron has already shown that, because initially only a few countries, now this week we already see more than 20 countries have that virus variant detected. So again, that speaks, the blanket travel ban is not really a magic bullet point. So, so I think that we need to bear that in mind. And the other important issues we wanted to make sure, essential international travel the seafarers, especially the seafarers who have been hit hardly by this pandemic, and they cannot function properly, which cause a disruption to the international or this essential travel, essential supply chain got disrupted. We have been working very closely with the International Maritime Organization, International Labour Organization, and trying to, to cascade down that message that essential workers, the international transport workers, they should be prioritized, and any measures. So we really called the collaboration between all these three organizations and to find the practical solutions to facilitate their cross-border movement. Otherwise, many of our, even the medical evacuation and also the transportation of the essential medicines, this will be also stopped. So I think this is also a very important message we wanted to reiterate. And then another very key point is that instead of only looking at the travelers, we need to actually to ramp up the national surveillance and sequencing capacities. We know some of the evidence already show actually the variants actually appeared not really associated with travel. So this gives a lot of, the thoughts whether this already in the community level, not necessarily travel is the let's say the essential factor that brings us to the entire world. So I think that's the national surveillance and response capacities, the sequencing capacities to improve that is continue to be the key for the strategy. And last but not least, I think the compliance with the preventive measures, the full package of preventive measures, the distancing, the hand hygiene, and the preventing avoidance of crowded space, and also the ventilation, good ventilation, so on and so forth. This remains the key package. And then we see that many countries are starting to relaxing, or the people, the population starting to, to feel relaxed with this type of preventive measures. And I think this is continues to be the factor where hamper the response and also the prevention of international spread. So all the travelers should really remain vigilant for the signs and the symptoms and alert to their healthcare providers when there's anything, and get vaccinated when it comes to your turn. So these are the key messages, and I think remain the key messages. Coming back to the point on whether the vaccines should be the only pathway to the international travel, we remain our recommendations that, and also this is recommended by EC. So the vaccination cannot be as the prerequisite to the international travel, because very obviously that we do not have the vaccine. All the countries do not have the same access to the vaccines. So the vaccine inequity continues to be the factor that again hamper the international response, because the more, let's say, the virus in circulation at the population, the more possible that we will have the mutation, and the more possible that the new variants will continue to emerge. So I think that you see the public call by our DG during the World Health Assembly special session last week. This week. So the vaccine equity is essential. Let's say the measure, and to make sure that we will see less and less the circulation in the population and the community level, and we could avoid the emergence of the new variants. So we have the target for vaccination, like by the end of this year, we wanted to reach that 40% of the global population have the vaccination, and by the mid of next year will be 70%. However, we already failed to reach the first target, which is actually by September, and to reach 10% of the global population to get vaccines. So I think that this this is something that's very urgent for us to address as a global community and the global solidarity. So we need to, again, to make sure that the vaccine equity will be addressed. So that's, again, speaks about our position not to require the vaccine as the only pathway to the international travel. So these are just a few points. If you allow me, I just wanted to add a few points on the presentations that you have made. I think that's very interesting. And from our side, we have been looking at the systematic review on the effectiveness on the testing, quarantine, and border closure. We know that from our first sweep of the systematic review, which actually has the cut-off date of November of last year. Now we just finished in the second sweep with the cut-off date of June. So we are asking the systematic review to add a quick rapid review to add a few months more, so we know a little bit more close to what we have now. And we do see that testing and quarantine and the combination of testing quarantine has some effects to reduce international transmission or slow down the international transmission again. But we also come back to the point, the risk tolerance. I think the risk tolerance and the risk, you understand your country's risk tolerance, and also looking at the different combination of the testing and the quarantine, they have the different, again, the risk residual. So we really need to have to compare what your expectation and also the risk residual associated with each approach. So I think that's the things that could inform your country's risk-based decision. So we will be very happy to share with you once the second sweep of the systematic review comes out. And the other comments before I pass the floor to my colleague Nat, sorry for taking some time, and I think it's very interesting. It's the economic cost, that presentation. I may have missed that factor, but apologize if I missed. It's about the health insurance. Have you seen that, also health insurance, this is the factor in the in this analysis, because we know health insurance somehow could have very positive impact on the travelers' willingness to travel, because they feel more safer to have the health insurance to cover. But it could also pose the negative impact if the health insurance is it's not very accessible to many people because of various factors. So it will be very interesting to see if you have any insights to share. Thank you. And then I will pass the floor to my colleague, Nat. Sorry again for taking so long time.
Thank you so much. We are so happy that you are willing to share so much with us. No worries about the time. Yeah, over to Nat.
Thanks. And thanks so much, Ninglan, for that comprehensive overview of everything. And thanks to the panelists for the research. I must admit, I am more of a digital health person, so I can only comment on the digital component, which I know is a very hot topic for this group as well. So just to react to Surin's presentation, in the WHO guidance, we completely agree that the digital certificates, although focus on digital verification, should also be available in a paper format. And this is very real due to equity issues, because quite frankly, most people don't have smartphones. And then the other thing to note too is that the digital certificates in general, and we have guidance for vaccine status that's already been published, and for test results for SARS-CoV-2 diagnostic test results coming up. And I can share the link to both of those things in the chat right after this, is that it is just a digital tool, and the certificate itself is a tool, and it has to operate within this complex policy environment. So it's really important to ensure that the policies are clear and in place before implementing such a tool. I think especially when going to digital, it does heighten the stakes a bit, because there are very real concerns in terms of data protection and privacy, in terms of potential belief that this certificate can surveil individual movement. Because the other important thing is too, although this conversation is focused on border control and international travel, once you have a digital tool in place, it can be used anywhere. Whether or not it works well or not, that's dependent on the design of the technology. But if you have a digital system set up, there is potential for misuse. So it's important to ensure that all these complex policy discussions And in terms of cross-border recognition and things like that, those need to really be clarified before designing the tools, because the technology exists. And I think you've seen already, there's technology from the European Union, there's one from North America on smart health cards, there's also specifications from the ICAO group, and our colleague here from IATA also has a solution in place. So there's technology already exists. I think that's my key message, and it can be a large investment or a small investment depending on the existing digital infrastructure in the country and the way that the solution wants to go, because there's also blockchain technologies available, there's also offline mechanisms available. But all this kind of pales in comparison to these complex policy decisions. So I would encourage anyone who's looking at digital certificates to really think critically about how they're going to be used, in what context and when, and then decide how that technology can fit that use case the best. And when you get there, we do have guidance on design principles, ethical use, minimum data sets, interoperability standards that can be leveraged. So I'll share that in the chat as well. And happy to answer any other questions. Thanks.
Thank you so much, Nat. And I think that is really a very key reminder that the tools are there, but we have to think very carefully about how we apply those tools. And it's really heartening that throughout our conversation, there is a lot of discussion about equity. And I think COVID has really brought to the forefront the importance of considering equity in all policy making. We will hear more about this, I believe. Moving on, let's hear from Dr. Vinoop, because I think IATA has been mentioned a couple of times, and maybe it's time for us to hear from him. Dr. Vinoop, Goel.
Thanks, but let me clarify, I'm no doctor and I'm not a medical professional. So my name is Vinoop Goel, and I'm the Regional Director for Airport and External Relations for IATA for the Asia Pacific region, and I'm based out of Singapore. So allow me to maybe comment from an aviation viewpoint, fully realizing that I'm probably the only non-medical person on this, on this webinar. And it is for us, in aviation, we do realize that COVID is a medical issue, but the impact on aviation has been devastating, and I'm sure, as you are very well aware, and especially in the Asia Pacific region, where international travel is only about maybe 6 to 7% of what it used to be back in 2019. And I think for a long time, us aviation professionals, we talked to ourselves about what we needed to do to reopen the industry and to start it. And I think very late in the game did we sort of realize that it is a medical issue and that the decisions are being made by medical professionals appropriately, and that we needed to work with them. And I think over time we have learned, and I think the industry has learned, how to first of all better explain what the impact has been, what the industry can do, and what is the role we can play. So, and some of the themes came out in the previous presentations from WHO and others. So what, from our viewpoint, we fully understand that the governments and other authorities are controlling this or are responding to a medical crisis and are trying to obviously reduce or minimize or eliminate the risk of importation of the virus, and which leads to border controls and border closures. I think there was some discussion on, what and the models, what kind of testing, how much quarantine you can keep. And I think what we expect from different governments is do your analysis, do a proper data-based analysis and respond accordingly to that. And I think, that's an easy thing to say. And fortunately, there are governments with that capability, but unfortunately, this is a new issue and a complicated issue, as is evident from the models that, Dr. Dickens talked about. It is complicated. Us in aviation sort of understand it a little, but for governments to take the right decision, I think it is incumbent upon those who know and those in organizations. We talk about vaccine equity. There needs to be knowledge equity, capability equity, right? So that the governments can respond appropriately based on data models and not on fear. And unfortunately, we thought that governments had learned and the industry had learned from the experience with the Delta virus. But as you have seen from the responses to the Omicron, no, it has still been quite a bit of knee-jerk reaction. This whole assumption that if I shut down my borders, I'm going to keep the virus at bay. And you're just buying yourself a little bit of time, while in the meantime, the impact on people, economic activity, livelihoods, and lives is at stake. What we need to do is to, first of all, ensure there is access to robust air connections for medical supplies, vaccines, and PPEs and all that. But also we allow essential economic activity to work, and based on the risk analysis of importation versus my own risk tolerance in my country. Now, if the vaccination rate in a country is 10%, I would probably have a much lesser risk tolerance than if my vaccination rate is 96% of eligible people, just as an example, right? So what we would like governments to do is to provide that, do that risk analysis, and then also come up with measures that are comparable or to that risk analysis, and look at what can be done to enable travel that can happen, businesses, families to reconnect in a safe and sustainable way. So a layered approach is needed. I do agree with WHO's position that you can't limit it to vaccinated people, but then there is a realization that vaccinated people do pose a much lesser risk. So you could have lesser quarantine, no quarantine, or no testing, but then also there needs to be avenues for the non-vaccinated people who can't get vaccinated for perfectly good reason to travel, based on some combination of testing and maybe some quarantine. So the industry is ready to support that. What we have seen is that passengers are willing to use, based on our extensive surveys, they're willing to use digital certificates. They're willing to share personal data as long as it's done in a privacy protecting manner, to allow themselves to travel. And what we are looking for is, some level of harmonization. Harmonization is an easy word, but like I say, we still as a world can't figure out which side of the road to drive on or which plugs to use for our PowerPoints. So it will take some time, but what we need is clear rules, harmonized rules, something that people can follow. And we do need a digital process. Unfortunately, I think there was some comment, you can get a fake vaccine certificate, paper certificate on the internet for X amount of dollars, or a fake paper certificate. And for border control authorities, it is almost impossible to verify a paper certificate in a fast manner. So what we are asking for is, let's look at the process. There's enough guidance from WHO, ICAO, and many other agencies, then from IATA, that allow borders to be open through a layered approach, which is safe and secure, but it needs to be harmonized so that it gives governments the confidence that anyone who is coming through has been checked, verified, and is following the rules, but also gives confidence to the passengers that where they're going, they'll be safe and they have the right testing and vaccination certificates, and for everyone else who is facilitating that journey, airlines, airports. So in a nutshell, I think, first of all, hats off to the medical community for all that you have done over the last 2 years. And believe me, we as an industry would love to have everyone travel at the same levels that they did in 2019. but we do realize it has to be done in a safe and responsible manner, and we are willing to play our role. Thank you for that. From a non-medical viewpoint for a medical issue.
Thank you so much, and I must apologize for the mistake in the title. I think the fact that we're seeing a diversity in responses from the countries this time round compared to when we were responding to Delta showed that we have improved a little. I do agree that there is a lot more room for improvement in terms of how we respond to new variants. And I think that Corizia in particular is set up in such a way to promote the knowledge transfer among 10 different countries and governments within Southeast Asia. So I am really optimistic that we will get better. But clearly, there is still quite a lot of learning to be done. And, you know, personally, I'm really delighted that even with the Omicron variant, the vaccinated traveling between Korea and Singapore, for instance, remains open. That must be very good news for many of my fellow countrymen. So moving on, so last but not least, our speaker, Dr. Professor Awang. Yes.
Sure. Yeah.
I'm trying to look for your video.
Can you hear me?
Yes, very well.
Yes.
Thank
Yeah.
you. Thank you for waiting.
Thank you very much. Yeah. Thank you very much for inviting me. Just a bit of clarification. I'm not really representing the Academy of Sciences Malaysia. I am Secretary General of the Academy of Sciences, but that's by it's a coincidence. I happen to head two committees in Malaysia. One is a research project called the COVID-19 Epidemiological Analysis and Strategies Research Project. And the second one is an independent COVID-19 Vaccination Advisory Committee, which was set up in December before we kicked off our immunization program. So my committee, the Vaccination Advisory Committee, called the ICVAC, we made a number of recommendations to the government when we kicked off our immunization program, and we thought that it would take us about 300 days to reach about 80% of the population, which is quite accurate. Actually, we are almost at 80% now. We are about 77% of the population covered by vaccination. We started vaccinating children under the age of 18 now. Next year we'll look at children below 12, and we've started our booster program for the seniors first and those who were immunocompromised and so on. And the rest of the population now have been invited for their third doses. So the interesting thing about Malaysia is that when we were talking about the vaccination certificates, because this cropped up very early on about the use of vaccination certificates domestically in Malaysia. So there was a lot of questions about whether we should look at paper certificates, because there were certain segments of the population which did not use smartphones. They were mainly rural folks and the elderly. But and there were two types of apps which were in use in Malaysia. It has now been centralized to a single app now called Natschja, which is what we use for just about everything now, for contact tracing, for vaccination, well, practically just about anything. So the Natschja contains the digital certificate for vaccination and so on. So almost anywhere that you have to go through, you have to check in, say a QR code that you have to check out to. Otherwise, you'll be presumed to be at that particular location for God knows how many hours, and that will complicate matters when contact tracing is done. And we have to show proof of vaccination and so on. Now, the thing about vaccination in Malaysia is that the federal government has mandated, this is a vaccine mandate, that all federal government employees must be double jab, must be vaccinated, unless of course they have opted for a Johnson & Johnson or CanSino vaccine, which is a single jab. And when we started off this committee, we did advise the government that not to rush into opening borders, but perhaps to look at the travel bubbles first. So the Langkawi Island travel bubble was open a few months ago, and we said that Langkawi would be a test case to see whether there'll be clusters of infections which result from people who are vaccinated, but whom we do not insist on quarantine. So tourists could come in, have a PCR test or RTK antigen test prior to their arrival in Langkawi, and they were allowed to roam the island. So far, nothing has come out from that travel bubble. So it is proving that it is possible to safely implement travel bubbles between destinations and between countries where the vaccination rate is high, they are vaccinated, and the infection rate is relatively low. So as you know, a vaccinated travel lane has opened between Malaysia and Singapore. That's been in existence for a few weeks now, I think. So we'll see how it goes. Fingers crossed. There have been a couple of infections, but I think I don't think there are large clusters of infection which have developed from that. So anyway, we hope that it doesn't. Anyway, now the thing about Omicron is very interesting. We knew that variants would occur. Variants is a normal part of any virus, particularly RNA viruses. They're going to mutate anyway, and there have been thousands and thousands of mutations. Now today, the health minister went on TV, he had a press conference. The first Omicron imported case in Malaysia has been detected. And the thing is, this particular student, he's a university student from South Africa, went back home for holidays, landed in Malaysia on the 19th of November. That's before the 24th, when Omicron was declared, I think, by the WHO. Now, what happened is that he was PCR tested positive. He's vaccinated. He was given home quarantine. Electronic contact tracing means that he has his contact tracing. So we don't think there's been any infections spread in the community because of that. And because there was a suspicion that there were some of these samples, so they did a backward trace of all the samples which have arrived, and between a certain date to Malaysia, and that was how he was found. Genotyping PCR found that it was possible Omicron, and whole genome sequencing was done. So it determined he was an Omicron case. So that's before 24th of November. So we know that Omicron had already arrived, but he's asymptomatic. He has been released from quarantine on the 29th because he served his 10 days of quarantine, and he has infected no one as far as we know. So we did about 3.2 million contacts through electronic contact tracing from the Natschja apps. And there's no first generation, second generation. Nobody seems to have contracted any infection so far. Fingers crossed. So don't know. Right. So how are vaccination certificates going to affect border travel? Now, this is something which I've been asked in the media before, and I have a caution about vaccination certificates before in the media because of the difficulty of regulatory bodies, for example, recognizing vaccines between countries, and the fact that it will disadvantage countries which, of course, have lower vaccination rates and so on, which we knew would be a problem. So we have not put this as a mandatory kind of thing, but we do test people who come into Malaysia who we have no travel bubble with us. So at the moment, what do we think about vaccination certificates? Well, any Malaysian who wants to travel overseas now has to prove that they have a Natschja proof that they have been vaccinated, and that can easily be confirmed. So what about domestic use of vaccination certificates? But unfortunately now, every shop that you have to enter in, you have to scan, you have to show that you have been vaccinated. And that has somewhat kept infection levels, I think, relatively low. And the infections in Malaysia have been really more of asymptomatic or very mild symptoms at the most. So the very severe symptoms have formed a very small percentage now, around 1 to 2% of total infections. So we think vaccination is working, although we are a little bit apprehensive about the elderly and so on, where waning immunity levels have been demonstrated. So we are pushing now boosters as much as possible. So what do you think? What do we think of the future? I think the government is looking at this very carefully. There were talk about moving into opening up borders more after the Langkawi travel bubble has proved to be effective, because there weren't too many. Well, there were hardly any infections. There were no spread from the Langkawi travel bubble. So we think that's the way to go. Open up travel bubbles more and more. I think the government is in discussion with Indonesia and a few other countries about opening more travel bubbles. But Omicron has put a dampener on the enthusiasm. I think they will be a little bit more cautious. and we'll see how it goes. That's all for me. I think I've talked too much already. Thank you very much.
Oh, not at all. Thank you so much. Yeah. On the topic of travel bubble, maybe we can bring it back to Prof. Kang. Does travel bubble work in the domestic context?
Whatever we've had with travel bubbles has been around requiring certification from people. The only time that we had quarantine for domestic travel and people needing to stay in. Sorry?
We'll need to mute. Yes, thank you.
Okay. So initially during the periods of lockdown, when there was internal migration at wide scale within the country, there were quarantine camps and isolation camps that were set up when you crossed a state border. Whether those actually restricted spread of infection is unknown, because when we look at seropositivity rates across our country, then they don't seem to show an effect of such activities. So I'm not sure that these kinds of approaches have worked in domestic travel. Since then, it's really been about having certifications to make sure that people have vaccine certificates before they cross certain state borders. This is non-uniform, so we don't know. With everything that we've done, unlike the nice modeling that we saw from Dr. Dickens, there's no such thing that has been done for data from India.
Right. I believe that we'll be very interested to work on that data if it becomes available. Yeah, but maybe over to Dickens. So Bo, would you like to comment about the ART versus PCR?
Certainly, wow, so many interesting comments. I could respond to all, but yeah, so certainly the PCR and antigen, rapid antigen testing. So that actually came out pretty much from the beginning after we first asked the question, what do we do? Like, we know that there's been this new disease that's emerged and travel is just continuing as normal. But and then as make sure I get the names correct here. Apologies, I'm very bad with pronouncing names. As Mr. Is it Goel? Correct, identified. There was a very knee-jerk reaction. A lot of countries started shutting down travel, shutting down borders. It was a very rapid cascade of events, which was very difficult for us to manage. But then there was the advent of, okay, we have PCR tests and we have rapid antigen tests. And at that point, there was this rapid need to then determine, okay, so what's the sensitivity? And not only what's the sensitivity, depending on your day of infection, your incubation period, are you close to becoming symptomatic? Are you asymptomatic? All these questions started emerging of, okay, what do we do? So PCR tests also required up to 2 days. And I think earlier on, even I heard of weeks of being processed due to these long queues of tests that need to be conducted. So then with the advent of rapid antigen tests, which is still an ongoing process of trying to determine their sensitivity with new brands coming out, new versions, or better versions, we came down to this idea of, okay, so maybe we should have to think of a mix. So, okay, should we completely exclusively remove PCR testing from border control? And the question really, I think, was a resounding no from the majority of both people in the airline industry as well as those in terms of looking after public health. But it's not feasible to be doing something like 3 to 4 to 7 to 8 PCR tests for some individuals in the peak of the pandemic. So we tried to come up with this mix of, okay, so maybe if you do a PCR test for the critical points of infection. Now, the one critical, I would say, resounding finding we kept determining throughout all these models was the first test is the most important. What I mean by that is the first test, regardless of whether it's 60, 70, 80% sensitivity, removes the biggest proportion of people from the population of infected. Subsequently, tests that happen after that are then removing proportions of those which are left. So whether it's PCR and antigen, the idea of antigen is that it is as effective as PCR, provided you do it repeatedly. So the one-time antigen test, it's largely you're going to miss a lot of people. And even within the community, we don't recommend you do one antigen test and that's it. For the whole year, you're definitely not like positive, right? We recommend you do it every 2 weeks or every week in some situations. So if we compared, of course, a PCR test with a 24 turnaround with a rapid antigen test, then you're going to have a PCR test performing incredibly better, much better. But the reality is that that's not possible, especially in some, we'll say, resource poor countries. That's simply not a reality that we can look at. So maybe perhaps we could use a mix. Now, what that mix should be, there's no one size that fits all. It depends on what rapid antigen test you have available. The supplies of that even is also under strain in some settings. So whether we can just determine to perhaps minimize or manage the risk is something I would say is more feasible with using these tests which are available. Should there be more PCR tests available, then of course you should bank more on that, but perhaps test less frequently if there's strain on laboratory processing times. If there is more rapid antigen tests available, then for sure you should repeatedly test people as often as possible, as the inconvenience of that is substantially less than doing a PCR test. So there's this balancing act that has to go on. And I think this doesn't only apply, of course, to international borders, but national borders, as well as even within like the community. So that has been an ongoing question we've been looking at with our modeling studies, especially with the advent of new PCR tests coming to market, as well as new rapid antigen tests coming to market. The government is very interested, I would say, in Singapore to know, okay, what's the best test that we can use, and what's the best combination, which is cost saving in terms of making sure that we identify people in an economically feasible manner, as well as being the most effective in protecting the public's health. Yeah, so that would be my response to that.
Right, thank you so much. And I do think that the flexibility of your model really allows for different users to customize the scenarios or the options according to their own local situation. So that in itself is very powerful and useful. We do have a comment in the chat to say that studies are ongoing on whether Omicron impacts the performance of ART. So I think we should keep a lookout for the evidence. And it's reassuring to know that RT-PCR is still effective to detect Omicron. And I think for several countries, they're doing a two-step process, right? So as in for Malaysia, I think Singapore as well, first they try to identify possibility. So preliminary analysis of whether Omicron might be present, and then before they actually invest in NGS, which is going to be more expensive and also takes a bit longer time. There are also other questions, but maybe at this point, is there anyone who wants to turn on your microphone? If you do, you can raise your hand. Otherwise, I'll be picking up a question from within the chat. All good? Okay, so let me see. Are there any studies assessing the effectiveness of vaccine certificate in reducing the risk of infection? I think this is a very good question. Yep. Does anyone here know? So Sarin, based on the interviews or the discussions that you had so far, are you aware of any ongoing study?
Not that we are aware of, Colin.
Okay, yeah. I think that's important, but it's also very, very difficult to do. And that's also when we talk about evaluating the effectiveness of various non-pharmaceutical interventions, it's really hard to tease them apart and to clearly attribute the effectiveness of any single measure. Yeah. Let me see what else is in the chat. Oh, okay, Professor Kang, yes.
Yeah, so I just wanted to say that a substitute for what we are looking for as an answer to the last question might be to look at effectiveness of vaccines in preventing household transmission. And those studies have been done for mRNA vaccines and for the viral vectored vaccines, particularly from the UK. So, but the big thing to remember is that a lot of the effect on prevention of transmission depends on which variant it is and the time out from vaccination. So you may start to see a reduction in transmission when you've been immediately vaccinated, and then 6 months later, it might not be there. So when we think about it, those are the kinds of things we need to consider, but it's not like there's no data.
Right, I see. And also I think in certain European countries, they have already started to put a validity date to vaccine certificate as well. Yeah, all because of concern over the wane immunity over time. Right. Let me see. What else is in the chat? So what do the panelists think about imposing vaccine mandates to curb the spread of COVID, right? Yeah. So does any of the, okay, Dr. Wang, please.
Thank you. I think in terms of to determine the effectiveness of the vaccine and no vaccination in the context of international travel, I think it's a complex issue. It shouldn't be looked at that, just as a single point, because we see very vast different picture now. Like the Western Europe, they have a very high vaccination coverage, but now the increase, actually Europe is almost the top 1 or 2 regions in the world. So that speaks again, the compliance or the adherence to the public health social measures also plays a very important role. So if we look at the effectiveness of vaccines, this has to be combined with the other parameters because it looks at, solar, looking at the vaccination, it doesn't give the full picture how that will really reduce or slow down the transmission or not, because it's not the determinant, let's say. Thank you.
Thank you. Yeah. Professor Awang?
Maybe Professor Kang would like to say. I think she put up her hand first. Yeah.
I'm sorry, that's an old hand. I'll take
that might be the earlier one. Yeah.
Okay,
yeah.
Right. You're talking about the vaccination mandatory mandate?
Yes.
Yeah.
Yes.
Interesting question. Now, we had a bit of a problem with this when I think the government wanted to have a vaccine mandate because there were government employees which did not want to get vaccinated, and they had nothing to do with the vaccine supply because we have plenty of supply of vaccines. So in the interest of safety, because federal government employees, I think, interact with the public on many levels, and some of these are healthcare workers, which made it even more difficult. So the federal government decided that it would make a vaccine mandate. And fortunately, there was no outcry from the unions. So I think that is now in force. And anybody who does not want to get vaccinated, who's a federal government employee, I am not a federal government employee, but I have been triple jabbed already. So still, there have been no outcry from people who did not agree with the vaccine mandate. And I think the public is agreeable with this particular move. We have not made a mandate for everybody else. It is not mandatory. In fact, even there was talk of changing the status of fully vaccinated from 2 jabs to 3 jabs, but that's still under consideration. So if you got two doses, you still considered fully jabbed. But there was already talk about the health minister on TV saying that they're considering whether it should include a booster before you're considered fully jabbed. Studies have shown, and this is on our own recommendation from our committee too, that we needed to study the B-cell, the T-cell immunity over time to see whether this would reduce. We should not just be looking at antibody levels. We know that antibody levels will decline, and probably a primary series where the interval between the first dose and second dose is as short as it is now does not perhaps allow for optimal immunity. I'm not immunologist, but I don't think it's optimal immunity when you have such a short interval. So possibly that has happened in this particular case. So in certain vaccines, we have found a reduction in antibody levels, which are a bit worrying. So we have made a triple jab available for anybody who had a Sinovac jab 3 months after their second dose, and a Pfizer jab 6 months after their second dose in Malaysia. And it is now available for anyone above 18 who wants to get a booster jab. In some states, they are proceeding with the booster jab very quickly. In the state of Sarawak, the biggest by area, not the biggest in population, by area, I think 30% of the population has had their booster dose, their 3rd jab. I think that because they're preparing for the state elections, which is going to occur this month, sometime this month. So they've been rushing the booster jabs to make sure that infection levels are kept down in time for the for the state elections. So vaccine mandate still iffy there, only federal government employees, but so far no protests from any of the unions, I think. And the acceptance rates from the vaccines has actually gone up. There was a lot of vaccine hesitancy in Malaysia in the very beginning, but because of the push, I think, the media and so on, I think almost everybody wanted to get a jab. And the cocktail of vaccines in a way helps in Malaysia, because we have quite a number of vaccines which are in use. We have Pfizer, AstraZeneca, we have Sinovac, CanSino, Johnson & Johnson. Moderna, we have approved it, but I don't think we have bought any supply of the Moderna vaccine, nor the Sputnik V. Sputnik V has not been approved, but there was talk about buying Sputnik V. Yeah. That's all from Malaysia.
Yeah. It's always a dilemma for me whenever I hear about countries discussing booster shots versus there are still many countries that haven't even gotten the first shots. I think that's always a challenge in terms of the vaccine equity. And clearly, if among us who are privileged enough to have access to booster shots, we should definitely think about how to increase acceptance of that and encourage more people to have their booster shots. And perhaps recognizing the booster as a full vaccination might be the nudge that we need for some individuals. Yeah. So we are getting very close to the end of this webinar. Is there anyone else who would like to raise a comment or a question?
I have a couple of comments on the chat, Hwee. I'm sorry about it.
Dr. Yat, would you like to read those questions out? I'm afraid I've got too many things in the chat and I might have missed it.
Okay, can you hear me?
Yes. Yeah.
Yep, I have a couple of questions. One is to Professor Kang, maybe also the visual. Having said that, children have a lower risk of having serious disease and higher risk of getting adverse effect of the vaccine. So I asked Professor Kang and the visuals what they think about should the visuals or countries have different criteria for approved vaccine for children as compared to nowadays that we are using the same criteria and we apply for both children and adult. And also to IATA, because now we have more and more children being vaccinated. So I want to know IATA positions on whether they prefer or they will not prefer to request children's vaccine certificate when they travel with the parent. Over to you.
So, Yot, if I can comment on these questions, I think, you know, the WHO principle of saying that you can't say that only with vaccination certificates you can travel, right? Is the appropriate principle to have. But countries have the ability to say, well, if you cannot have a vaccination certificate, you will have to comply with requirements A, B, and C, whether that is testing or a certificate of infection or some period of quarantine. And I think the sooner we can get to a standardized protocol for all of this, the easier it will be for everybody. Or, you know, if what WHO lays out right now is just that we don't agree with mandating vaccination certificates. And I think that's fine. I think when it comes to children and whether children need to have certificates in order to travel, that's a really interesting question, because many countries at the moment have not mandated or even had approved vaccines for children. And I see this getting more complicated in the future, because we will wind up in a situation that where the bulk of the vaccines available in one country may not be vaccines that are actually approved for children. Take the AstraZeneca vaccine as an example. It is used in over 40-year-olds in the UK. It's used in 18 plus in India, and is very unlikely to be used in children anywhere. So how will we make a call on what to do? I think, again, developing a policy that says if your country has vaccination for children, that's great. If not, these are the preferably requirements for testing of children if they travel with or without their parents. I don't think necessarily banning children or having, well, one other thing I can think about is I know that most parents who have children who are going to be traveling with them would be very happy to get their children vaccinated. It's just been that their countries have not had vaccination for children. So one option to include in the menu for children might be the opportunity to get a dose of vaccine if they land in a country where vaccinations are available for children. So it's an evolving and complicated situation.
Yes, indeed. Mr. Vinoop, would you like to chip in on that?
No, I think if I got the question right about just students, you know, from our viewpoint, it's again going back to the data-driven approach of managing risk. The risk posed by a student versus a non-student is the same thing, right? Yes, yes, there is a question about children, but generally, what we say is, yes, for vaccinated people, the risk is much lower. So government should look at, again, based on data, trying to see if quarantine is not required. But for those who are not vaccinated, you should have another process which reduces the risk through testing and whether it's multiple testing. So you have an avenue for people who are not vaccinated, but it all comes down to how do I equalize the risk, right? Because from a border control perspective, that's what I'm trying to do, is to manage my risk, importation risk into my country.
Thank you. And Ninglan, would you like to add on?
Yeah, thank you. Yeah, just for children, I think I fully agree with Dr. Kang was mentioning, because in WHO's policy document, we are not saying that, they have alternate for people who are not vaccinated to travel, because they can use the testing and the quarantine as required by the countries. However, I want you to also mention that children are not really in the high-risk group that for recommending of the vaccination. However, we need to also acknowledge that for the children with underlying conditions, they should be also recommended for vaccination. And this is quite clear in our SAGE recommendations and for different vaccines, because the vaccines require, they have requirements that what products fit for what age of the children. So I just want to differentiate. One is the non-high-risk group, which is the normal, the children with normal condition, and the other is the children with underlying conditions. So they need to be protected for developing severe disease. Thank you.
Thank you. Thank you very much for that. Yeah. So as the chair, I would like to exercise my right to ask the last question. And that goes to Mr. Vinoop. Essentially, I think many of us are interested to look at the non-medical data, travel data in particular. Is there a mechanism for us to collaborate with IATA in any way?
Yes, sure. We do put out, we have access to quite a bit of data. We do put out some of it publicly, but please get in touch with me and we'll see what is available. The caveat there is some of our data is provided on a commercial basis because we have to fund our own salaries. But please get in touch with me. I'll put my email address in the chat, and then we can see what collaboration we can do.
Thank you so much. I think we really look forward to that. So if I were to summarize, so thank you once again to the speakers. I think definitely having a model to provide a crystal ball into the various possible scenarios and to anticipate some of the unknowns is really helpful here, especially a flexible one that Bo's team has created, which allows different countries to customize according to their local needs. But clearly we need some form of harmonization. And I think I hear that repeatedly, harmonization of policy, harmonization of vaccine, or rather our responses or attitude towards vaccination, whether it needs to be mandatory, whether a certificate, digital or otherwise. And also I think largely all of us yearn for some degree of normalcy. We really wish to go back to where we were pre-COVID. However, we need to make informed choices about what to relax and what to continue to keep a lid on. And I think for that purpose, there is really a need for continued conversation, such as the platform that we have here today. And therefore, I want to thank all our speakers as well as the panelists for your generous sharing. And I certainly look forward to the next time that we can convene together again. So before I end the webinar, maybe I would like to invite all of you to join me to thank the speakers as well as the panelists. So we won't turn on the mic, it'll be too noisy. So if you can use the reaction button and just give our speakers and panelists a round of applause, that'd be greatly appreciated. Thank you. Yep. Okay, so I'll call an end to today's webinar, and thank you so much for joining us today. Thank you very much.
Thank you very much, Chair and everyone.
Thank you very much. Stay safe, stay healthy. Bye-bye.
Stay safe, everyone.
Thank you.